I'll be speaking on how to do it. Endoscopic fusion. Already Dr. Sukumar has given you a good idea about how endoscopic fusion can be performed. I'm just enumerating the steps, taking on through how it is done. So the concept of fusion evolved, from Clowards, which did a classical PLIF, to TLIF from Professor Harms, and a modified version of it is done endoscopically because you don't need too much of space. You have a lot of space available. Plus, you can retract the neurological structures. So you can do what is called as a limited resection of the facet, wherein you just remove the horizontal component of the superior articular process, retain the vertical component. Advantage of this is going to be you're retaining the musculature, the attachment of the muscles on the lateral side, that is the SAP, which also preserves a lot of blood supply, which will enhance the fusion rates. So why change? Well, we are all doing surgeries. If somebody is not able to perform endoscopic TLIF, doesn't mean that he cannot do it with other routes. Well, there are definite advantages. Reduces access trauma to the skin and the paraspinal musculature. Ability to operate under very clear field because of the saline irrigation. Able to visualize inside of the disc for very good end plate preparation, and earlier mobilization and shorter hospital stay. Patients usually are discharged within 24 hours of the surgery. So, is it feasible? Yes, definitely feasible. These are some anatomical studies which are published. Amount of space that is available is abundant. So, if you are able to do a good dissection and remove part of the horizontal component of the SAP and the IAP complete, you are able to put in a beautiful normal cage. So, these are the dimensions. Lot of space and area is available. There are people who are also putting smaller size olive cages through the tea leaf roots also now. But yeah, we need special kind of retractors and technique for that kind of a procedure. So let's get into the technique. You can divide the technique into 5 different components. One is the docking, which is absolutely important because you have to be parallel to the disc. Okay, you can translate your endoscope, but then you defy the purpose of doing endoscopy. That means you don't want real muscle stripping. You want to retain the muscle. So there is no translation of the endoscope. At the most, you can angulate it a little bit so that to give you that kind of a position. Second is decompression, which goes without saying. Most of our patients are just not instability, but they also need a lot of direct decompression. End plate preparation is of importance, cage implantation, and posterior instrumentation. I prefer to do it bilaterally, though I have done a unilateral facetectomy. So let's go through a case here. So this is a 57 male, pain in the back and lower limbs, predominantly on the left side. Claudication distance about 10 meters, left EHL and is about 3, left ankle dorsiflexor 4, straining on micturition. You can see quite a bit of stenosis at the level of L4-5. Severe stenosis on the axial sections. If you can see the dynamic x-rays, which are standing dynamic x-rays, you definitely have a mobility at L4-5. The patient is slipping at L4-5 on flexion. So how do we start? Before we start, we need to understand the technology a little bit. The tools that are required, the drilling tools, osteotomes, Kerrison rounges, different kinds of burrs, because you may have a difficult area or a difficult axis. The nerve roots may be adhered, thecal sac may be adhered. So you need tools. Now the first important thing, as I told you, docking. Now for a classical interlaminar surgery, you may go obliquely inside because the interlaminar window is usually a little caudal. But for a fusion surgery, you need to be absolute parallel to the disc space. So you need to do a translaminar surgery. So you dock on in line with the disc here so that you don't, while cleaning up the end plate or preparing the end plate, you don't create end plate fractures. So that's the most important thing. The docking has to be kept in mind. Next comes is decompression. This is a diagrammatic representation for people who have not understood how endoscopic fusion is done. So you primarily dock either at the medial pedicular border or the mid pedicular border, depending upon how big the facet is and how much is the interpedicular distance. Once you have done that and you put your scope inside, normally the scope that is used for this kind of a purpose is a stenoscope, which is a 5.7 millimeter working channel endoscope. You start trimming either from the spinolaminar junction or from identifying the tip of the inferior articular process. Once you have done the ipsilateral lateral recess decompression, this is just, I'm showing diagrammatic. We do most of the things with the osteotome so that we can harvest a lot of bone graft. So the contralateral is done in the similar way, retaining the ligamentum flavum, and then you remove the inferior articular process. Now, when you remove the inferior articular process, I always tend to keep a tug of bone more cranially, which is overhanging the exiting root. This ensures that the ligamentum flavum in the bone is protecting the exiting root all the time. So I now have to deal with only one baby, that is the traversing root. So once I put my cage inside, then I can comfortably decompress the bone over and the ligamentum flavum over the exiting root, starting from the lateral recess to the extraforaminal region, which just becomes pretty easy. So you don't have to really worry about the exiting root all the time when you're putting your cage inside. The protection will be from the bone and from the ligamentum flavum. End plate preparation, how do we do it? Do we get a chance to do a proper end plate preparation? Yes. This is the resection of bone which I have already done. You put in your dilator, you put in your sleeve intradiscal. And now you have a lot of mobility. So about 60 to 70% of the disc can easily be done with the help of these kind of instruments. Now you have some articulating instruments also which will give you more access. But by and large, this is sufficient that you are able to do a good, by retracting the thecal sac a little bit, you can go far on the opposite side. You can radiologically confirm that you are way too anterior at least at the level of the annulus. So you can do a good end plate preparation on the ipsilateral, central and the contralateral side. Now, how do we put the cage? Now putting the cage, there are multiple ways of putting the cage. Now you have to only deal with the traversing route. So you can put any kind of a semicircular retractor, you can put a sleeve, whatever is comfortable for you, you can do it. Turn it around, check it with your endoscope at all the time that you have retracted your traversing route properly. And once you have done that, a gentle maneuver and there you get absolute center into the disc through the area. So you can put it absolutely anterior and then the cage can go in. So initially we used to use all these expandable cages, but nowadays we use the regular 12, 13, 14 cages for most of our cases. So here's a representative video. So let's see docking. So you dock on the cranial lamina in line with the disc space. Extraspinal clearance. This is important to strip away all the soft tissue from the bone, because once you harvest the bone, then it is extremely difficult to remove this soft tissue from these small pieces of bone. So remove it right inside, strip it off completely, and once you have done that, identify the tip of the inferior articular process on the caudal lamina. Start with the cranial laminotomy, just burying a little bit so that you remove the remaining part of the soft tissue which is adhered to the bone, and then start harvesting bone. Use an osteotome incrementally from the tip of the inferior articular process. So start chopping off the inferior articular process from caudal to cranial. The extent of removal of this should be at least to the level of the inferior end plate of the cranial vertebra, because that is going to be the corridor through which the bone is going to go. Go on the contralateral side, retain the ligamentum flavum on the ipsilateral side, do a contralateral perfect decompression. This ensures that there is not too much of bleeding when you are doing this. Flavectomy in ipsilateral side and contralateral side is performed. So you remove the entire ligamentum flavum, decompress the roots well, confirm axilla, root, everything is free. If there are some fragments of the disc which are migrated, can be removed completely. And then you start with the cage entry site preparation. So once you have removed everything, this is the part of the pedicle, left side is the cranial, this is the vein which is a connecting vein which usually bleeds, so you need to take care of that. Turn the sleeve of your endoscope so as to protect your traversing route and make an annular opening at the medial pedicular line. So this is interpedicular. Go with the standard shavers that are available. You don't need endoscope here. Well, you can do it with the endoscope also, but completely remove, denude, remove all the cartilaginous end plate from the end plate, which is very, very easy and absolutely not difficult, because your endoscope is quite mobile. Size your disc space, pack it with sufficient amount of bone graft, which you can harvest about 10 to 12 cc of bone graft comfortably. Put in your cage, look for the perfect location of the cage, and then you can turn the cage, and that's the final entry. So the cage is completely inside, and now decompression of the exiting root if required, not required in all the cases. So you just have to go over the roof of the axilla, identify that area, and start coming out laterally till you reach the extraforaminal zone and see a completely free exiting root. So you can see some bleeders here because of the chronic inflammatory condition. So this is the part of the ligamentum flavum which we had retained initially, which was protecting the exiting root. Just 10 seconds. So you can, once you see it comfortably going out, you can probe it. Final confirmation is done before, because you may leave some loose pieces of the bone in the epidural space. And so confirm that the entire decompression is done, cranial, caudal, ipsilateral as well as contralateral. Retract and see that the thecal sac and the roots are completely mobile after you have put in your cage. See the cage perfectly sitting in there, and then you can start with the augmentation posteriorly. So we put in this kind of vertical mattress sutures here because normally this surgery takes about 1 hour 40 minutes for one single level without the posterior instrumentation. So the decompression and the cage implantation. So this is the final construct. Thanks a lot for your patient listening.